All right, so we'll go ahead and get started. So today's webinar is essentially going to go over a little bit about pneumonia and influenza, more from a clinical perspective. From if you're seeing the patient with pneumonia, what kind of things you should be thinking about, and also following the Infectious Disease Society of America guidelines. So that's kind of where it's coming from. So this first slide is essentially just to show the Infectious Disease Society of America website where you can find the guidelines. So an easy way to find it is to go to Google and type in IDSA Guidelines cellulitis or IDSA Guidelines pneumonia. And it should come up, or you can just go to the website like this and type in IDSA Guidelines and it will come up, and then you can search for the guidelines you're looking for.
And the nice thing is the guidelines are all free. It's accessible to anybody. So it's a really nice area to find everything that you guys need to look up.
Yes, and this is where we get our recommendations. So if we ever discuss a patient and then you'll say, where are they coming up with these recommendations? Feel free to ask us and we'll send you the guidelines and refer to the part that we're coming from. So as it comes to which antibiotics to use, the duration of treatment, really a lot of these questions are straight from the guidelines, and we're happy to send you the guidelines about the patient that we're discussing. And this is the one we're going to start with. This is Infectious Disease Society of America guidelines on community-acquired pneumonia. So they have several different guidelines. Some of them are older than others, and they come out and update them frequently. Following the infectious disease guidelines has been shown to have better outcomes for patients. So, and they'll actually do studies, and they'll look and they'll say, does following this recommendation have a better outcome? And if it doesn't, then the next time the guidelines come out, they drop that recommendation. And so the guidelines are meant to keep getting better and better. So just following the guidelines, patients have better outcomes, and so that's what we try and follow with as far as our recommendations go. So to get started, I thought we'd go over quickly the CURB 65 score. So CURB 65 are for patients that already have a pneumonia. So if you decide this patient has a pneumonia, where should I send them for treatment? So should I treat them as an outpatient? Should I treat them as an inpatient? Or should I send them to the ICU? And the first question is, why is that important, sending them where they get treated, if they get treated as an outpatient versus inpatient versus ICU? And the reason is because patients that go to the right place and get treated in the right setting have better outcomes. So they do studies where they look at patients that went to a medicine floor that get transferred within the first 48 hours to the ICU. So those are patients that probably should have gone to the ICU instead of the medicine floor. And if they're transferred, if they go to the medicine floor and then they transfer to the ICU within 48 hours, the outcomes are worse than if they had gone straight to the ICU. So in order for providers all to do the same thing, so every provider looks at a patient and it comes out with the same recommendation of where to go, they come up with these scoring systems that are trying to be based on objective findings looking at the patient. So instead of, and in that way, one provider won't look at the patient and say, oh, they don't look too sick, and another provider will say, oh, I think they're really sick. They can come up with an objective scoring system. And this scoring system is one of the reasons it's really good is because it's so simple. There's a CURB 65 score, which is this score, which is easily remembered because you can just look at it and remember it. But other scoring systems, there are some that are actually better, but they take so many variables that it's too hard to do in a clinic setting. So the CURB 65 score has been validated, and here the C starts for confusion. So if the patient is newly confused, the U is for BUN. So if the BUN is high, it might show that they're dehydrated, they're not doing as well. The respiratory rate, 30 breaths a minute or greater. The blood pressure, if they have hypotension, and then age 65 or greater. And then you can look at this and you can see that the only thing here that's a lab is the BUN. So if you see the patient and you say they're confused, the respiratory rate, they have hypotension, you can look down, you can say they already need to go to the ICU because they have 3 points already. So you wouldn't need to get any labs or do any other testing. You can look at the patient and say, this person needs to go to the ICU. All the providers that use CURB 65 should come up with the same scoring system. So that's something that's in the guidelines that I think is very helpful. So that's the CURB 65 score for patients that already have a pneumonia. Let's see. We'll move forward. And this is a most common bacteria in different settings. So if a patient develops community-acquired pneumonia, if they're treated as an outpatient and they're not that sick, these are the things that they probably got them sick. Inpatient, non-ICU, they have a different list of pathogens. And inpatient ICU, it's a different list. So part of that is what can make a person that sick. So strep pneumo, you'll see, is on the top of every list. And so for that reason, no matter what you're treating with pneumonia, you always want to treat strep pneumo really well and make sure whatever regimen you're giving, you're treating strep pneumo. Staph aureus, you'll see, is on the ICU list, but not on the other lists. And Legionella is also something that if you have an ICU patient, you want to make sure that you're treating Legionella and Staph aureus, whereas in the other settings, it's not as important to be thinking of those pathogens and treating and covering those as if they're in the ICU. So sometimes on test questions, they might say something like, an HIV patient comes in that's not treated. What antibiotics do you want to give? And you need to remember that although a lot of people jump to a lot of the things that only affect HIV untreated patients, you want to make sure that you're treating strep pneumo as well, because strep pneumo is the most common problem, and HIV patients as well, you want to be covering if you're covering a pneumonia. So here we'll move forward. So community-acquired pneumonia testing. So when you're treating someone for pneumonia, you want to make sure that you order a chest x-ray to see that they actually do have a consolidation or an infiltrate on their chest x-ray. You can order blood cultures before they get antibiotics, would be most helpful. Sputum culture. Sputum culture, sometimes it doesn't help, but when it does help, it really helps, because then you can target that organism and you can get rid of all the other antibiotics that you don't need. When available, a Legionella urine antigen. So a Legionella urine antigen, if it's positive, that's something that you want to make sure you're covering. If it's negative, it might not be so helpful because they may still have Legionella, but if it's positive, you want to make sure that's covered. Pneumococcal urine antigen is another urine test, and procalcitonin. So if you're able to do a procalcitonin, we recommend it. And so it might take 6 to 8 hours for it to go up. So if they get immediately sick and come into the ER and the procalcitonin is low, if you check it the next day, it might be really high. And then as you continue to trend it, which is the most important thing with procalcitonin, is continuing to trend it, you want to see it come down and improve. And that would mean that a good prognostic factor. That would mean you have the right antibiotics. If it continues to go up, then you'd want to consider changing antibiotics to something else. We're going to have a separate webinar just on procalcitonin.
Yeah. The nice thing about procalcitonin is if you guys are convinced somebody has a viral infection like influenza or RSV and they have no lung infiltrates, otherwise they're pretty stable, and if you get a procal and it's negative, then you could kind of reassure the patient. Also, you could reassure yourself that you don't need to add the antibiotics and just treat the symptoms or the antivirals.
Yes. Yeah, that's exactly right. So procalcitonin is used to stop antibiotics. You don't really use it to start, more along the lines of if you check a procal and it's low and you check it again the next day and you're already thinking, I think we should stop giving antibiotics, and the procal is low, that supports your decision to stop. Yeah. So we found it very helpful. You wouldn't use it as the only thing, but we wouldn't use WBC as the only thing, or whether they have a fever is the only thing. You kind of look at it all together. So here we have community-acquired pneumonia outpatient treatment. And we have previously healthy, no risk factors for drug resistance. You can give a macrolide. This would be azithromycin, clarithromycin, erythromycin. Most of the time, if something's given, it's going to be azithromycin because it's the best tolerated. But in regions where there's high rates of macrolide resistance, consider an alternative agent, such as ceftriaxone, cefprioxime, ceffuroxime. Nationally, the macrolide susceptibility is around 69%.
And then when I looked at Nebraska data too, at different places, we are up to like 30 to 40% resistant. So if you truly have pneumonia and the patient has risk factors, we should not be using macrolides at all as a 1-8 drug agent.
Yes, so azithromycin, I think we use it a lot, but I think if the patient doesn't do well, or if you have a better option, then I would say consider other options. And this isn't something just in Nebraska, this is something nationally. That next time they come out with guidelines, they may even remove azithromycin. I don't think it would be too much of a surprise. And doxycycline would be another one single drug treatment, another option. And then this next slide, this is outpatient treatment or inpatient, but not ICU. So these you could use as an outpatient treatment. A respiratory fluoroquinolone, like levofloxacin. More and more they're coming out giving warnings about levofloxacin, probably because it's given out so much. I mean, it works very well, but I think because of so much is given out, they're finding a lot of issues that they may not have otherwise.
Yeah, especially with arrhythmia and all the FDA warning and linked to C. diff infections as well. So if you have other options, it's better to use that. But moxifloxacin, levofloxacin is a good option when we need to have a monotherapy drug.
Yeah, and what makes it a respiratory fluoroquinolone is that it covers strep, staph, and because it covers some gram-positive, that's why we'd say levofloxacin. So you wouldn't use Cipro, but you might use levofloxacin because it has strep and staph coverage. A beta-lactam plus a macrolide. So this is another option for outpatient or inpatient non-ICU. You can give ceftriaxone or ampicillin sulbactam plus a macrolide. So if you're thinking maybe they have an aspiration pneumonia, ampicillin sulbactam will give you additional coverage of anaerobes, gram-positives, covers gram-negatives. So if you want to give them some additional coverage, you can give them ampicillin sulbactam. Ceftriaxone would work well also. Now, when we look at this regimen, ceftriaxone plus azithromycin. Now, covering atypicals is part of the reason for the azithromycin, but really it's to double cover strep pneumo. So double cover strep pneumo, and the patients that get this double coverage actually have better outcomes. There was a study through Mayo Clinic that looked at this, and they had patients that had pneumonia, community-acquired pneumonia, that had bacteremia with strep pneumo, had better outcomes if they had double coverage for that strep pneumo, which is odd because that's something we normally wouldn't do. Normally we would say if it's susceptible, we can go with one agent. But whether it was ceftriaxone plus azithromycin or ceftriaxone plus levofloxacin, they had better outcomes. And so patients that are extremely sick, might be an elderly patient, 80 or 90 years old, coming in with a really bad pneumonia, they're not looking good. I would recommend giving two agents for that reason, because they had such large studies that showed better outcomes.
And one of the biggest, like Dr. Horn was saying, reasons for pneumonia, strep pneumo. So I think that macrolide has shown better outcomes. And they believe it has to play a role with anti-inflammatory property. So a lot of the macrolides have a lot of anti-inflammatory property as well. So I think that might be playing a role. More studies to come, but better outcomes with double coverage. So I think that's another reason for that.
Yeah, so they didn't see synergy. So synergy would be faster killing when it's in a test tube. But in this, it wasn't synergistic. So they're thinking other properties like inflammatory, like anti-inflammatory properties, which makes a lot of sense, I think. So there are some of the regimens.
Any questions you guys have so far?
So now we're going to move on to community-acquired pneumonia inpatient ICU. So if you have an ICU patient, so I included this chart again to show the inpatient ICU organisms. So you have strep pneumo, number one, Staph aureus, Legionella, and then gram-negatives. And here, so when you choose the regimen, you want to choose something that will cover the organisms here. So we have piptazo plus levofloxacin plus vancomycin or linezolid. So here, the levofloxacin, you might say, oh, well, we already have Zosyn. Why are we giving levofloxacin? In this situation, it's to cover for Legionella. So if you do a Legionella urine antigen and it comes back negative, and then you say, I don't think this patient has Legionella, then you can stop levofloxacin.
The interesting thing about Legionella is that there's a lot of different species, but the majority of the infection is caused by type 1, and majority of the time, about 70% of the Legionella infection. So if you are able to get Legionella urine antigen, that's awesome, because that way you could kind of, if it comes back negative, you could get rid of the levo, but if it's positive, then you could actually treat with levofloxacin.
So here we've got Zosyn, and so that has good gram-positive, gram-negative, anaerobe coverage, and then levofloxacin for Legionella, plus vancomycin for MRSA. And that's kind of the thought behind, and this is all community acquired. Now, we're going to move forward, and it gets a little bit more complicated, but this is the management of adults with hospital-acquired and ventilator-associated pneumonia. This is a recent guideline, came out in 2016, and this one, and this is the reason I was showing where to find the guidelines, because this is really hard to remember, and so I sent out the PowerPoint so you can use it as a reference sheet. So you can, if you need a quick reference, you can bring it up and either bring up the guidelines or bring up this PowerPoint and just kind of look at it. So it's not to memorize. I think it's just something to look at, know when to refer back to it. So this is suggested empiric treatment options for clinically suspected ventilator-associated pneumonia in units where empiric MRSA coverage and double anti-pseudomonal gram-negative coverage are appropriate. So then the question would be, when would MRSA coverage and double anti-pseudomonal gram-negative coverage be appropriate? So it all depends on the local antibiogram. So, and if you don't have an antibiogram, I would probably still cover it. But
Yeah.
It depends on, well, it depends on the local antibiogram and then how sick the patient is, and is the patient immunosuppressed, kind of their background. So if they're extremely sick in the ICU and they're immunosuppressed, or they have a lot of comorbidities and you're really wondering about it, those are times I would say to add the additional coverage and make sure they're covered. If they're not very sick, then that's the reason why you don't jump to so many antibiotics so quickly.
And also, if you don't have an antibiogram in your hospital, you could also use a regional one as kind of a guiding tool as well. So that's another option.
So this is suspected ventilator-associated pneumonia. So you're going to choose one from each category. So the first category is gram-positive antibiotics with MRSA activity. So vancomycin here works. Then the next category is a gram-negative antibiotic with anti-pseudomonal activity. Then a gram-negative antibiotic with anti-pseudomonal activity, non-beta-lactam. So you're going to choose a beta-lactam active against Pseudomonas, and then a non-beta-lactam to have different mechanisms of action. So you wouldn't want to choose antibiotics that have the same mechanism of action. It'd be less likely that it would work. So here we can choose vancomycin, and then the next one would be piptazo, and then the next one, levofloxacin. So you can see in this instance, it's actually a different reason for giving levofloxacin. So here, the levofloxacin is to double cover for Pseudomonas, whereas a community-acquired going to the ICU, the levofloxacin there is for Legionella. And again, if you have an antibiogram and you know your antibiogram is 96% for Zosyn, then you may not need to give double coverage for Pseudomonas. If you say our antibiogram is extremely poor for Zosyn as well as other things, then you might want to give more coverage.
Yeah. And then sometimes fluoroquinolones, the susceptibility to Pseudomonas is only like 70% at certain places. So then you might do an aminoglycoside like a gentamicin and Zosyn instead of Zosyn and levofloxacin. So it all depends on your kind of hospital needs and antibiogram.
And if the patient has a beta-lactam allergy, you might do vancomycin, and then instead of giving piptazo, you would go down to aztreonam and levofloxacin. So then it would be a different option for a patient with a beta-lactam allergy. And then here is another big table. These are recommended initial empiric antibiotic therapy for hospital-acquired pneumonia, non-ventilator associated. So the ventilator-associated pneumonia was the previous one, and those patients can be extremely sick. These patients can too, but this wanted to give kind of a risk stratifying option at the top. So if they're not at high risk of mortality, so they're not that sick, and then no factors for MRSA, you can give one of the following. The next option, they're not that sick, but they have likelihood of MRSA. So then you'd give one of the following plus vancomycin or linezolid down here. And then the next option would be they're really sick and they've gotten antibiotics in the past 90 days, so you want to cover them for drug resistance. So here you would choose one from the top, and it says 2 of the following, avoid 2 beta-lactams. So that's similar to the previous chart. So you'd choose 2 of the following plus vancomycin or linezolid. So, and again, as long as you know to reference these charts, this isn't something you would really have to memorize. So that's kind of covering community-acquired pneumonia. Then now we're going to move on to flu.
Any questions so far on pneumonia? I know we kind of went through all that stuff fast.
It's a lot of information, yeah.
If not, we could wait until the end as well, but kind of go through flu a little bit. Influenza has kind of been very high right now everywhere. The biggest strain is H3N2. It's influenza type A. That's what's in our community. And this graph is from the CDC. So the red area is the H3N2 strain. I'll let you change that. Thank you. And this graph kind of shows us over the last 4 years how the trend has been, especially in pediatric associated deaths. Already, we're only in the middle of influenza season, and we have had about 30 pediatric deaths so far. I'll get to why it's important, because pediatric patients are a really high-risk group, so we need to be aggressive treating them. And this graph kind of nicely shows throughout US who's getting admitted mostly to the hospitals with influenza being confirmed. And if you can see, over the age of 65 have the highest rate of in-hospital admissions in all the age groups. This graph is kind of nice because it kind of shows us from 2009 all the way to now, the different influenza curves. And if you look at 2009, it was right here, we had an early peak in influenza season. Currently, the red graph is where we are, so we're still on the peak. So everywhere currently influenza cases are coming, it's still positive, lots of people are being affected, so we need to be kind of keep an eye on this and treat patients appropriately and get patients vaccinated if they have not received vaccinations yet. So kind of the symptoms to watch out for influenza. One of the main symptoms is fevers. But remember that when elderly patients, sometimes they might have other symptoms, but they might not be able to mount a good fever. So they might have cough, runny nose, but not have a fever. But we should also think about influenza on elderly patients and make sure to test them as well. And other symptoms and signs are muscle aches, headaches, lack of energy, a dry cough, sore throat, nasal congestion, runny nose in some patients. So, so wide variety of signs and symptoms. So this is why this patient group is really important. We just talked about there have been more than 30 pediatric deaths nationwide due to influenza. And who are the high-risk patients that develop complication? It's kids less than 5 years of age. The really concerning in this age group is 2 years or less, but 5 years or less is also. So I would say anybody less than 5 years of age is really high risk. Adults greater than 65 years of age, pregnant females, and also 2 weeks after postpartum, the females are really at high risk as well. And also American Indians and Alaskan Natives are at high risk as well. And then other comorbidities that you have. So a lot of our patients have some or multiple of these comorbidities, like asthma, neurological issues like seizures, chronic lung disease like COPD, cystic fibrosis, heart disease, CHF, coronary artery disease, blood disorders like sickle cell, endocrine, metabolic disorders like diabetes, kidney disorder, liver disorder, cirrhotic patient, weakened immune system, so our cancer patients who are getting like methotrexate and immune modulators for like rheumatological disease, or inflammatory bowel disease patient like Crohn's and ulcerative colitis, kids receiving aspirin because of Reye syndrome that puts them at high risk for influenza complication, and morbid obesity. So for that, they say BMI greater than 40. So if you think about it, a lot of our hospitalized patients have a lot of these comorbidities. So it's important that to get them vaccinated and also treat them with antiviral Tamiflu. So testing has been another challenge because right now influenza is widespread. So if somebody presents with influenza-like illness, you can assume they have influenza without testing. So those symptoms and signs we talked about before, so if you have a patient in hospital or outside with these symptoms, we could assume and they treat them like they have influenza with Tamiflu. Patient can be diagnosed clinically and do not require influenza testing for clinical management, including antiviral decisions. When prevention prevail in the community, a negative influenza test is likely a false negative. So a lot of places we are using rapid influenza test, and it's not very good. It's only sensitive and specific 65–70%. So let's say you're seeing a patient at bedside and they really look like they have influenza and your clinical decision says they have influenza, we should treat them for influenza, because during the peak season, when you have a rapid test that comes back negative, it's usually false negative. Wouldn't you agree?
Yes, and the converse of that is in the summertime, if you check influenza and it's positive, it's most likely a false positive. But now if you check it and you're seeing a lot of patients with influenza, if it's negative, it's most likely a false negative. So it kind of depends when you're doing the test and what population. So I think that's exactly right. We should be treating patients regardless. So if you see a patient and you say, this looks like influenza, it's an influenza-like illness, you can go ahead and give Tamiflu, and whether you even test it or not, well, I guess we'll get there, but, yeah. but you should definitely be putting them in isolation and treating them.
And that's key too. If you have any patients in the hospital, we should be doing droplet precautions, so masks and good hand hygiene is very important. And we could assume during the season, if anybody comes with influenza-like symptoms, you could assume they have influenza and treat them with antivirals.
Yes, and also some of the questions we've been getting about patients with influenza, they'll say, oh, you know, it's past 48 hours. So because it's been longer than 48 hours, I'm not going to treat them.
And then that's why that high-risk group that we were just talking about, and patients with comorbidities, even if it's past 48 hours, you should treat them with Tamiflu. So CDC is kind of recommending, like even after 48 hours, if they have symptoms, treat the high-risk group definitely.
Yes, and if they're admitted to the hospital or they're going to the ICU, you should be treating them. Yeah. You shouldn't say, oh, it's longer than 48 hours, I don't want to give it to them. It's not going to hurt, and it might help. It might really help the patient.
And also another thing is, let's say you have in the clinic setting, or you in the ER, we're seeing a pregnant female, and then her daughter has influenza. We should prophylax the mom with Tamiflu to make sure that she doesn't get it, because The high risk group is really important because they're the one that's getting affected the most. So let's say we have a granddaughter that gets diagnosed with influenza, and they have an elderly grandpa who's 80 years old that lives with them. He should get prophylaxis, because the high risk group, we should be making sure we prophylax them. And this is another nice graph, just like what we talked about from CDC. They want us to kind of a decision tree. So does the patient have signs and symptoms suggestive of influenza, including atypical clinical presentation or findings suggestive of complication associated with influenza? If it says no, you're good. Don't worry about it. But if it says yes, the patient being admitted to the hospital. If it's no, will influenza testing change your clinical management? If you say no, then you could just go ahead and treat them, and then make sure if you need to prophylax the close contact.
Yes, and influenza testing can be pretty expensive. So some of the facilities we work with say, we're spending so much on influenza testing, and if they're seeing a whole lot of it, or if they just suspect it, they can just treat, and they don't need to spend the money on testing. Yeah.
And then the other decision tree down here is, if the patient is being admitted to the hospital, test for influenza, start antiviral therapy. So that's the important thing. Don't wait for the results to come back. If you're admitting somebody, just start them on antiviral, and then you could wait for, if you are testing, you could wait for the results to come back.
And then sometimes when they're admitted to the hospital, they're not put under in precautions until it comes back positive. So if there's a lag time, so then the nurse is exposed, and then you have providers in the hospital that are exposed to that patient who may be spreading it within the hospital if they get it. So putting them in the proper precautions would be.
Yeah. At time of admission, if we suspect it, we should be putting them in isolation. Any questions you guys have so far? You could go ahead and type some too if you want. This is really important too. So during influenza season, when patients get influenza, they're really at high risk for getting secondary bacterial infection. And some of these infections, and the biggest bacteria to worry about is Staph aureus, Strep pneumo, and also some gram-negative bacteria like Haemophilus influenza. So they all like to adhere and cause infection when it could happen when you're having influenza or post-influenza. So it's really important to, if you're worried about bacterial infection, to treat them with the proper therapy. So getting sputum culture is very important. And if a patient is pretty sick, making sure we cover both for strep and Staph aureus. So we could probably do like vancomycin for MRSA coverage, and ceftriaxone for gram-negative and strep pneumo coverage as well, double cover with vanco and ceftriaxone. So that might be a combination that you'll do if a patient is really sick, influenza, plus you're worried about bacterial infection. You could do vanco, ceftriaxone, and Tamiflu to kind of cover your bases.
Yeah, and when people have a viral infection like influenza or RSV or anything, and then they get a bacterial infection on top of it, Staph aureus is a big player. So before, when I went over the causes of community-acquired pneumonia, the bacterial causes, Staph aureus didn't show up until the ICU. But if you have influenza or RSV and then you develop a bacterial infection on top of it, then you want to make sure you cover Staph aureus. And this is a favorite because strep pneumo is always number one, but then after influenza, some studies have Staph aureus number one or number two. So Staph aureus moves either into number two or number one spot after influenza. So one of the favorite test questions would be, patient is diagnosed with influenza, they're starting to improve, and then all of a sudden there's a sharp decline in their improvement, and then they do very poorly. So then it'll say, what antibiotic do you want to use? And you want to make sure that you use something that covers Staph aureus, and even MRSA if they have a lot of hospital exposure or they've had it in the past. Yeah, that's one of the favorite test questions.
And I just wanted to kind of show some viral bronchiolitis infiltrate. So when you get a viral infection, you kind of have like hazy, sometimes some atelectasis infiltrate. But when you have a secondary bacterial pneumonia, you have major consolidation. So you could clearly see how lobar consolidation, different lobes of the heart, lungs are affected by the bacterial pneumonia. This is on a chest x-ray showing here, and right here in a CT scan. So that's kind of like a difference between viral and bacterial pneumonia too, and also the importance of getting the x-rays. So there are three antivirals that we have for influenza. We got Tamiflu, which is oseltamivir, which is oral, which everybody's very familiar with. Then we also have inhaled zanamivir and intravenous peramivir, which is a newer drug, came into the market a couple of years ago. So oseltamivir is great because you could give it in any setting. It's given orally. But sometimes you do get patients who are intubated, they cannot take anything oral, they're throwing up, lots of other things that are complicating things. So zanamivir is an option, it's an inhaled version, but you cannot use it in patients who have lung issues such as COPD or asthma because they'll cause bronchospasm. So so you cannot use it in that patient population. But if you look at peramivir, it's really nice because it's IV form. So those patients in the ICU or critically ill who cannot take oral medication, this is an option that we have as well. Works really well. So we have 3 different agents, and the nice thing is they all work for influenza A and B. And Dr. Horn and I were just looking at the other day to see resistance with these medication. There's less than 2% resistance, so they're very effective.
Yeah, I believe it was H3N2 has the less than 2% resistance. Yeah. It's very small. We did get a question. It says, for the precautions, are you recommending droplet precautions?
Yes.
So yes, that's droplet is what we recommend. So that's just essentially just a mask.
Yeah. You don't even have to wear gloves if you want, that's fine, but it's good mask and good hand hygiene. Before entering the room and after leaving the room, soap and water, good hand hygiene.
And another question we get is, how long do you leave the precautions there?
Mm-hmm.
Yeah.
And usually precautions should be left inpatient setting for 5 days. But if there's, even after 5 days, if they're still having fevers and influenza-like symptoms, then you should prolong that for a little bit longer.
Yes, so you want to make sure that they've gotten treatment and they're improving. So you want to make sure they're not still having fevers and issues when you take them out of precautions and expose everybody. Yeah. And
then we just wanted to highlight that point again for high-risk patients in inpatient or outpatient setting. We can give Tamiflu even after 48 hours. So we should not hold back antivirals, because what it does is it kind of cuts down the viral replication and shortens the viral infection. So, and also they become less infectious to other people.
All right, well, I think that concludes our talk, but if you have any questions at all, let's see, we can unmute everybody. And feel free to ask any questions that you have at all.
And you could type in questions as well.
There, we're unmuting everybody. So go ahead and ask any questions that you have.
I have a question. It doesn't sound like your rapid test for the influenza makes any difference at all.
Yes, the rapid test it's a rapid antigen test, and it's not as good as the PCR test. And it's so we actually in the hospitals that we work in, we recommend not using it. So if your suspicion is high, you just go with your clinical suspicion. If you're able to do a PCR test, like a BioFire test or a nasal
respiratory viral panel,
that would be the best thing.
Yeah, PCR is really good because it's 95% sensitive and specific. But when it comes to rapid, it's only 65-70%. So if it's positive, it's great. So then we treat them. But we worry about the patients that ends up showing up as negative, but they have the symptoms, clinical symptoms, and you're still suspecting they have influenza. If you still do, we should treat those patients.
Yes, and I believe there's a new rapid PCR test that's
going to be coming
gonna be
up.
available, or it's already available. I want to say it's $50 or $60 per test, but when it comes to putting a patient or exposing patients or treating, when it comes to treatment decisions, it's actually, you know, if it's a rapid test that can be done in the clinic, that's a PCR test, that would actually save a lot of money. So that's something that's coming. We haven't transitioned to it yet, but yes, we don't really recommend the rapid. And if we do have a patient sent to transferred to the hospital, we might recheck the PCR. It kind of depends on the situation, but we can. But if our suspicion is high and we have a negative, we might repeat it, or we might just continue to treat. Yeah. But I'm saying I wouldn't trust the test, is what I'm saying. Yeah. More frequently, we'll have patients that have all the symptoms that are transferred to the hospital, but they have a negative rapid. And in those situations, we'll say, well, we don't want to expose people if we don't have to. And those are the cases where we'll really want to, it make more sense to test in those situations where we have a negative test, but we don't want to expose anyone in the hospital if we don't have to.
Okay.
Any other questions we have?
Not from here.
All right. Well, thank you, everyone, for joining us. We'll have another webinar in several weeks, which we'd love to hear anyone's feedback. If you have feedback about this webinar, or if you have topics that you'd like us to discuss, we'd be more than happy to go over really any topics that you have.
We're learning along with you guys too. So anything we could improve, any suggestion you have, let us know. We're thinking next month we're going to talk about UTI treatment and asymptomatic bacteria.
Okay.
Perfect. Thank you.
All right. Thank you, everyone, for joining.
Thank you.
Thank you.